Hello, welcome to this video about the management of thyroid nodules.
My name's John Kassler. I'm a head and neck surgeon here at Mayo Clinic in Florida, and I'm part of a team that takes care of patients with thyroid nodules and other thyroid disorders.
And I'm Dr. Victor Burnett, chair of the Division of Endocrinology at Mayo Clinic here in Florida, and I'm also a thyroid specialist and lead the medical side of the thyroid team in regards to the management of patients with thyroid nodules and thyroid cancer.
So we're both speaking to you without masks. That's because we're in the privacy of our offices and the doors are closed. So we are observing social distancing and other safety precautions in the COVID era.
That's right.
So Vic, we're going to be talking a lot today about thyroid nodules and about thyroid cancer. But before we get into that, could you give us a little background on what the thyroid gland is and what the thyroid gland does?
Sure, John. The thyroid resides in the anterior portion of the neck. It is a butterfly-shaped gland and it makes thyroid hormone. Thyroid hormone impacts almost every tissue and organ we have in our body and helps it work better. A little bit like oil in your car and keeping the machinery running well. Thyroid hormone can make us make sure we don't feel cold or that we have weight problems, because when we have a deficiency of thyroid hormone, those kind of symptoms can happen: weight gain, feeling cold, dry skin, and such. John, many patients ask what a thyroid nodule is. Could you elaborate on that?
Sure. So you can think of a thyroid nodule as being a lump in the thyroid gland. Now, sometimes the lump is just part of the normal thyroid tissue that clumps together. And I think about it as lumpy gravy or lumpy pancake mix, that you have some lumps of the material in there. But also the other kind of lumps could be tumors, where you have either benign or malignant tumors that also can form a lump in the thyroid gland. Now, nodules or lumps in the thyroid gland are reasonably common. We know that about half of our population, or 50% of our population, has at least one thyroid nodule. We also know that thyroid nodules, along with other thyroid disorders, are much more common in women than they are in men. While they can happen in men, they're much more common in women. The other thing to realize is that as we get older, the incidence of thyroid nodules or thyroid lumps increases. So Vic, since we're talking about thyroid nodules, how does a patient know if they have a thyroid nodule? Are there symptoms that would alert somebody that they might have a thyroid nodule?
Sure, great question, John. And patients have this question all the time. So thyroid nodules many times have no symptoms. It is true that we have patients occasionally present because they say, oh, when I was applying makeup or shaving, I noticed a knot in my neck, or I swallowed while I was looking in the mirror and I noticed a prominence, and that leads to an evaluation. Actually, a lot of times patients have imaging for other reasons, like they get a CT scan because maybe they have neck pain, or a carotid ultrasound to look at their carotid for plaques and such. And so then incidentally, a thyroid nodule is found. It's not really common for patients to have pain from thyroid nodules. Every once in a while, a patient will say, oh, I had a little bit of discomfort, and that brings it to light, but that's not super common. The other thing is some patients present because they have a general enlargement of their thyroid, which we call a goiter, and they have some nodules with it. And that may cause a tickling sensation in the throat, occasionally breathing problems if it's a very big nodule or goiter. And also, hoarseness can be possible sign or symptom, although it's important to realize that hoarseness can be from postnasal drip or gastroesophageal reflux. And so hoarseness is not always connected to the thyroid or the presence of a thyroid nodule, but it is a potential symptom. Also, I think it's worth mentioning that thyroid nodules typically do not impact thyroid blood tests. And so usually thyroid function is very normal in patients with thyroid nodules. Every once in a while, we have a patient who will develop hyperthyroid type symptoms from excess thyroid hormone. And that's because the thyroid nodule is overactive. But that's a small percentage of nodules. And nodules usually don't lead to hypothyroidism or underactive thyroid symptoms because they don't make the whole gland not function well. Although patients can present with hypothyroid type symptoms and have nodules because both can occur concomitantly. So John, can you please explain the process of evaluating a thyroid nodule?
Sure. This is something that happens quite commonly in our practice. Sometimes the patients will present to an endocrinologist, sometimes they'll present to a surgeon, or sometimes they'll present to another physician, maybe a family practitioner. But basically, the workup for thyroid nodules starts with history. Getting a good medical history from the patient is very important. The symptoms that you mentioned earlier about hot or cold, dry skin, weight loss, weight gain, those are all important symptoms. It's also important to ask about prior exposure to radiation in the head and neck area, because radiation exposure is a known cause of thyroid cancer. So we want to make sure that we ask about that. The other thing we want to make sure is that we talk about the patient's family history. So a lot of times there are some thyroid issues that tend to run in families, and we don't want to miss that. So asking them about their family history is very important. After the history, we do a very thorough physical examination of the neck, where we examine the thyroid, we look for nodules, we get an assessment of the size of the thyroid. We also look for lymph nodes. We can't forget that there could be lymph nodes in the neck that are related to the thyroid gland. And then as a surgeon, one of the things that you want to make sure that you're assessing is the vocal cords, because the thyroid gland sits in front of the vocal cord nerves, and thyroid problems can affect the vocal cord nerves. So after the history and physical examination, there are some blood tests that are important. You mentioned patients that have an overactive thyroid, so you want to make sure that you don't miss that. So getting a TSH and a free T4 is important. Again, depending on the history, you may want to get some other blood tests that look for antibodies that might be associated with some thyroid conditions like Hashimoto's thyroiditis or Graves' disease that could be causing a patient to have thyroid problems or even thyroid nodules. Once the laboratory examination is done, the next step usually is to get a thyroid ultrasound, unless the patient's hyperthyroid and we go a different route. But thyroid ultrasound is really probably the best examination radiologically for the thyroid gland. When we do the ultrasound, we're looking at the gland itself to get an idea of the size of the gland. We're looking at the nodule or nodules and looking at the characteristics of those nodules. We're also wanting to make sure that we don't overlook the lymph nodes of the neck. So you have to make sure that you examine both the thyroid gland, but also the lymph nodes in the neck. So at Mayo Clinic here, when we do a thyroid ultrasound, we make sure that the lymph nodes are examined as well. The appearance of the nodule on the ultrasound examination may determine whether the nodule should undergo a biopsy. We do what's called a fine needle aspiration if we decide to do a biopsy based on the characteristics on the ultrasound. That will help guide us in our management. Now, Vic, I know you do a lot of needle biopsies of thyroid nodules. Can you talk about that a little bit?
Sure. So fine needle aspiration was a procedure that was developed in the 1970s and early 1980s. And it was developed because at that point in time, many thyroid nodules were just taken to surgery, and there was no good way preoperatively to figure out if thyroid nodules were cancerous or not. The FNA was developed, and what it allows us to do is insert very thin needles, thinner than blood drawing needles, and obtain cells. These cells can then be examined by a pathologist, or more specifically, a cytopathologist who has special training in reading such slides, and then tell us if there is evidence for the cells being benign, which will be reassuring. Is there evidence of cancer? And then sometimes it's an in-between diagnosis called indeterminate, where the nodule is not definitively revealing benign or malignant cells, and that potentially leads to additional evaluation. The FNA procedure is very simple and overall well tolerated by the majority of patients. I will note that the idea of a biopsy can be a little bit of something that makes a patient nervous. My experience has been patients will sometimes come into the procedure admitting that they're a bit nervous about the biopsy. And once we've completed the fine needle aspiration biopsy, they usually are like, wow, that wasn't a big deal. I wouldn't have worried about it, and have tolerated it exceedingly well. So it's a very straightforward, easy to do procedure that really helps us with evaluating patients. So John, the other thing to talk about is what do we get from these FNAs as far as diagnoses and such. And again, 80% of the time, FNA yields benign cells and tells us that we really don't have to worry about cancer. And then, like we mentioned, there can be cancer cells. That happens maybe 5 to 10% of the time. And those indeterminate cells that I mentioned happen maybe about 10 to 15% of the time. There is some variation from institution to institution on how often that those particular results will happen. John, I think at this point, it would be helpful to review how thyroid nodules are typically managed.
So we rely heavily on the appearance on the ultrasound. We have some guidelines from the American Thyroid Association and from the American College of Radiology to help us understand which nodules are more likely to be worrisome, things like microcalcifications, irregular borders, things like that. But then we also rely heavily on the results of the needle aspiration, the needle biopsy. Fortunately, there has been a standardization of the reporting language for needle biopsies. This was done at the National Cancer Institute in Bethesda, Maryland, a number of years ago, and we now have a common language that will communicate from the pathologist to the clinician what the risk of malignancy is and what the management should be. So, for example, in needle biopsy results where the result is positive for malignancy or highly suspicious for malignancy, those nodules are managed surgically by an experienced thyroid surgeon. Nodules that are benign or nodules that are too small to biopsy are generally handled by observation with serial ultrasound examinations at various times. The in-between ones that you mentioned before, those indeterminate nodules that are neither clearly benign or clearly malignant, now can be managed with something called molecular testing, where we can peer into the cells themselves, examine the DNA looking for mutations that are more likely to be associated with malignancy. So the ability to perform molecular testing can guide us in terms of whether we need to take a patient to the operating room or whether we can simply watch their nodule. What our practice here at Mayo Clinic is to save a specimen from the needle biopsy with all patients in case an indeterminate result occurs. We can then pursue this molecular testing to help us guide the management. If there are worrisome mutations, those patients will go to surgery. If there are no mutations or there are very favorable molecular markers, those patients can be followed similar to benign nodules.
Thank you, John.
So Vic, let's say your patient gets the diagnosis that their thyroid nodule is malignant. Obviously, nobody wants to be told that, but can you tell us a little bit about the prognosis for thyroid cancer?
Sure, John. While there can be exceptions, fortunately, most patients with a diagnosis of thyroid cancer will do exceedingly well. It usually does not cause life-threatening problems. It's important, however, that any thyroid cancer management plan be individualized to the patient and the medical facts at hand. There is important to avoid overtreatment of thyroid cancer, which is a possibility, and making sure that we optimize and get the right treatment for that patient based on their preferences and what the medical facts show. I will say one of the benefits that we have here at Mayo Clinic is being a recognized cancer center, which has a team of specialists, and we can ensure the most up-to-date management for patients, including we have endocrinologists like myself who are thyroid specialists, thyroid surgeons like yourself that have extensive experience in doing thyroid surgery. We have medical oncologists, radiation oncologists, interventional radiologists, nuclear medical physicians, and other specialists, and that we work together as a team and actually even have a tumor board where we will review cases and come up with recommendations for the management of that case. So I think that's all very important to understand and realize that most patients with thyroid cancer do well, but it's important to get individualized care. John, can you please summarize the main points of the information we've just discussed?
So we went through this pretty quickly. There's a lot to summarize, but let me just say that as far as thyroid nodules go, people need to understand that most thyroid nodules are benign. So ultrasound is an extremely helpful tool in the assessment of thyroid nodules and can really guide the clinicians in their management. Some of the ultrasound images show us characteristics that may lead us to want to do a needle biopsy. So a needle biopsy can be very helpful. It can determine risk of malignancy, and it can help with the management. Molecular testing can also help us, particularly in the indeterminate nodules, those that are neither clearly benign or those that are neither clearly malignant. And then the team concept to management is extremely important. As you mentioned, we work together as a team. We see patients together. We correspond frequently with patients. We correspond with each other, and we meet every other week with our thyroid tumor board. So that allows us to bring the expertise to bear from numerous different sectors of our practice to give patients an individualized approach to the management of their particular nodule.
Thank you, John. Well, folks, John and I hope that you found this information useful and that you feel a bit more educated about thyroid nodules and their management. And we thank you for your time, and take care and be healthy.
Nice chatting with you.
Same here.